A miniature horse or pony presents with extreme lethargy and a total refusal to eat. This clinical state points to a negative energy balance, a condition where the body's caloric requirements exceeds its intake. This deficit is often sparked by routine stressors, a sudden change in diet, the physiological strain of transport, or the high metabolic demands of late pregnancy can push these animals past their metabolic limit. Once this threshold is crossed, the animal's visible health deteriorates with startling speed. This rapid decline characterizes the condition, equine hyperlipemia. This condition is more than a simple side effect of starvation. It is an extreme, systemic metabolic overreaction specific to these small breeds. To identify the mechanics of this overreaction, we can compare the miniature horse to a standard horse facing the exact same caloric deficit. The standard horse's physiology adapts safely. It mobilizes fat stores at a controlled rate to maintain blood glucose and cellular function without entering a state of crisis. Simultaneously, the miniature horse experiences a sudden pathological spike in circulating blood lipid levels. This creates a clinical puzzle. Why does the same caloric trigger lead to safe adaptation in one horse, but metabolic collapse in the other? The explanation is found in the inherent metabolic profile of these breeds, which are predisposed to a massive and poorly regulated mobilization of fatty acids. Understanding this predisposition requires a look at the cellular level, specifically within the adipose or fat tissue. Adipocytes function as specialized storage units, holding highly concentrated energy in the form of triglycerides. Accessing these reserves depends on hormone-sensitive lipase, or HSL, the enzyme that initiates lipid mobilization. When active, HSL cleaves the triglycerides, breaking them down into free fatty acids that the body can use for fuel. In a healthy system, this is a slow, controlled drip. The fatty acids enter the bloodstream in precise quantities to meet immediate energy needs. This regulation ensures that fat release sustains the animal without overwhelming its circulatory system. This regulatory control is primarily managed by the hormone insulin. While well known for its role in glucose transport, insulin has a secondary, vital function in lipid metabolism. Insulin acts as a powerful biochemical inhibitor of the HSL enzyme. When insulin binds to receptors on the adipocyte membrane, it sends a signal that actively suppresses HSL, stopping the mobilization of fat. This ensures that the body only taps into its long-term energy reserves when insulin levels are low, keeping the metabolic system in balance. Essentially, insulin acts as the metabolic barrier that prevents an uncontrolled influx of fat into the blood. The core pathology in miniature horses is insulin dysregulation, a systemic condition where the insulin signaling pathway is compromised. Due to this dysregulation, the adipose receptors become resistant to the insulin signal. Even if insulin levels are high, the cell fails to respond. This resistance causes the inhibitory mechanism to fail. There is no longer a signal to stop the breakdown of fat. Unchecked, the HSL enzyme begins rapidly shredding the triglyceride stores at a frenetic pace. The ultimate result is a sudden and massive release of free fatty acids that completely floods the animal's circulation. The clinical crisis begins here, with a total failure of cellular communication and a loss of control over lipid mobilization. This volume of free fatty acids enters the systemic blood flow all at once. The sheer concentration of lipids turns the blood plasma thick and milky, a state known as lipidemia. This lipid-heavy blood is carried directly to the liver. Under normal conditions, the liver processes these fatty acids, packaging them for export or oxidation, but its capacity to do so is finite. As the flood of lipids arrives, the liver's capacity is instantly breached. The excess fat is forced into liver cells, causing massive accumulation. The liver is not failing because of an internal defect. It is simply drowning under a disproportionate and unchecked supply of fat. This accumulation, hepatic lipidosis, leads to severe organ distress and triggers systemic inflammation. The resulting hepatic dysfunction causes extreme nausea, which entirely destroys the pony's drive to eat. This anorexia deepens the initial negative energy balance that started the crisis. This worsened deficit signals the body to mobilize even more lipids, creating a fatal metabolic spiral where the animal's survival response actively destroys its organs. The pony is now trapped in a self-feeding loop of metabolic collapse. Veterinarians often compare this to feline hepatic lipidosis, but the two conditions are mechanistically distinct. In the cat, the problem is export. The liver loses the ability to package and move fat out. In the pony, it is exclusively a problem of supply. The liver is functioning, but it is overwhelmed by the failure of insulin-mediated inhibition at the fat cell. Recognizing the glowing, overloaded organs of an affected animal helps illustrate the true nature of the condition. Understanding this paradox of supply allows clinicians to target the underlying insulin resistance, breaking the cycle and saving the patient.